So we'll start talking a little bit about cervical spine today. Forget this stuff. Okay. So the protocol stuff here is all outdated, so let's forget this stuff. So typically what is a fairly standard protocol, and I think that spine protocols are a little bit more standard than the knee protocols. Knee protocols, every institution you go to has a little bit different protocol. Spine typically have a T1 sagittal, a T2 sagittal, and a stir. It's pretty common practice. And usually axial T1 and axial T2s through the cervical spine. And there's some variation. Some people like to do oblique sagittal images through the foramina to see the foramina better, but that's not very standard. In the early days, we also worked on some doing flexion extension views of the cervical spine, similar to the lumbar spine. We ended up dropping those. They really didn't add really enough. So, why don't we start here? Sam, what do you think of this case in a 13-year-old?
So, sagittal IR, I guess. I don't think that's cord, right? That linear low signal up top.
Right up there, yeah. What is that? Okay, here's an axial image right through that area.
Well, I don't actually see cord there. It looks like
The cord
was way anterior.
Right here.
Yeah, so this is a T1. This could be.
No, that's a T. This is an axial T2 and a sagittal stir.
So, looks like.
That's one cut. Here's another cut.
Okay.
Here's another cut.
Yeah. I wonder if this is just like ovoid of some sort.
Yeah. So these are flovoids. So I bring this up in the first time we started doing cervical and thoracic MR. It was something people just hadn't done before, and we saw flovoids. Whoops. Like this basically all the time in the very early studies, because we first started doing this in about 1984, and we got the first clinically available superconducting whole body scanner, and the first installation in the world in the clinical setting, not a research setting. And we saw these, and so we thought, first thing was, oh my gosh, we're missing all these AVMs or malformation and so forth, because it's so sharply defined. We kind of thought, well, if it's flovoids, it's not going to be sharply defined like this. But these are flovoids. This is normal CSF flow. And people, we then went through a lot of different techniques to try to minimize it. So it's very much minimized in current technology from the way they do it. But just be aware that you can have a lot of flow effects here, which is still occasionally I see from time to time. But it's not like in the old days when it was very obvious like this. But just be aware that you can get some funny flow things around the cord, especially in the upper thoracic and the cervical spine sometimes. So we talked about cervical diseases. We're going to talk about degenerative disease. We've already talked a lot about that in the area of the lumbar spine. And then some congenital developmental inflammation, trauma, syringomyelia. And then I'm not sure this year we'll get to neoplastic disease. We've already talked about the fact that spine problems are common. They're very expensive. And so I won't go back through this again. And we've seen all of those. And then typically you use the same nomenclature for cervical disease as we talked about with the lumbar disease. I like to use a North American Spine Society classification. And you can see annular fissures up here, just like you can see in the lumbar area. And they have the same significance here and down here. Very rarely these can be due to an acute injury. 99% of the time, these are really degenerative changes in the annular fibers. And here, this shows the high intensity zone right here. Notice the flow voids that you see in the CSF in this case. But that's just a typical high intensity zone. It has the same criteria. Then the termination for herniation is the same as we talked about before. So you've just recently seen these slides. I won't show them. In the old days, we used a lot of gradient echo type imaging in the cervical spine for reasons we don't need to go into now. We've got much better technology now, but here we can see a nice focal protrusion of a cervical disc. Here it is in the midline. And this is windowed, so you can't see the cord, but obviously here we have a cord, not nerve roots. So herniations can have a little bit different impact because you've got a large cord that you can compress and affect. Okay, and then protrusion, extrusion are all the same. And then you can get an extrusion like this with migration up and down. Same terminology we talked about before, so I'm not going to spend a lot of time. Here we can see a big protrusion here, but remember you got a big cord here, so we're actually getting flattening and deformity of the cord, which is something I always comment on. The important thing, though, is to then look carefully on the sagittal sturs to see if you have edema or signal change associated with it. If you see signal changes associated with the cord, it has a much worse prognosis than if you don't have signal changes. This was actually pretty well documented as caused by a roller coaster ride. The patient was completely asymptomatic before the roller coaster and had really pretty profound neurologic symptoms that happened immediately getting off the roller coaster. So be careful when you go to Magic Mountain. Yeah. And here's another acute extrusion. Now, in the cervical spine, we've got some other factors that can be helpful for us. If you actually have an acute extrusion, and here we can see the cord compromise, you have the history, but also you can notice here that there's kind of an acute angulation at the level of the pathology. And as you all know, one of the things that happens in the cervical spine, it happens to the lumbar spine also, but you just don't see it on MR, is you can get muscle spasms to help try to stabilize the cervical spine, and you can get kind of an abrupt angulation of the spine at that level in the acute setting, and once the spasms go away, you can go back to a more normal lordotic curve. So that's something else to look for. If you're in the setting of a major trauma, the muscle spasm is usually associated with hemorrhage into the soft tissues anteriorly. That's if you have a fracture or fracture dislocation sorts of things. But you can also get muscle spasm just from an acute disc herniation as well, which is what we're seeing here. And here we can see that big acute disc extrusion here compressing the cord. And here's just another extrusion. I don't want to spend too much time on this because we've already talked a lot about disc protrusion. And as we talked about before, the best evidence that goes along with symptoms in the lumbar spine are really foraminal zone protrusion affecting the nerve roots. In this particular case, we can see some disc migrating away. Another big disc extrusion with migration and cord compression as well. And here on the T2, we can get the hint that there may be some edema, but it's really important to do the stir. I still see some imaging centers that are trying to skimp on time, not do the stir, and I think that's a major mistake. Because if you're actually dealing with significant pathology in the cervical spine, the stir gives physiologic information, which is critically important in making decisions. And and here we can see the disc extrusion. And then sequestration is the same as definition before in migration. So we're familiar with all of these things. So here we have a sequestered migrated disc in the cervical spine. And as in the lumbar spine, if you wait, most of these will resorb. So in the old days, we thought that was a definitive indication for surgery, but now we're back in a situation where these extruded discs, we know in 9 months to a year they will be resorbed. So we're now more and more reserving surgery to people who have a pain that you really can't manage any other way. Otherwise, wait and allow this to resolve, because we know at 1 year there's no difference in patients' symptoms between whether they have surgery or not. But okay, and again, and you can see the extrusions also in the thoracic spine. So this is all kind of, now in the thoracic spine, often when they're chronic, they'll actually calcify. So in fact, you can actually have ossified disc extrusions Those are uncommon in the cervical and lumbar, but in the thoracic spine, uh, even though disc extrusions are much less common in the thoracic spine, when they do, they're more likely to calcify if they're chronic. Okay, and then we've talked about location of where they're located. This is centrally, and then and here we have another extrusion here. And it is interesting, if John Yurgudis were on the phone, which he's not, he would ask you what's the most common cause of a disc extrusion, or what's the most common association with a disc extrusion in the cervical spine. And he would say development of acute pain at night, basically in bed. That's a really common thing that he heard in his practice, where it really starts. So it makes you kind of wonder about traffic accidents and things like that being a major cause of disc extrusions. And we've actually had 2 fellows here who came in with that exact story. Acute pain at night and so forth. We did MR scans. They looked like this. Both of them elected not to have surgery. And in about 9 months, they were pretty much asymptomatic again. But it was pretty painful for the first 3 months. So that's a subarticular-zone extrusion, left arm radiculopathy. In this patient, we can again see this is the left subarticular and foraminal zone, really compressing the nerve roots in that location. Okay. Hamid, what do you think of this one?
Okay, so on to sagittal images.
I'm not sure I see anything here.
Yeah. Just that change.
Okay, so there's the axial,
The right.
and it was right side. This is through the C6. Doesn't look too bad. The regular sagittals, you can't really see much of anything, which is not that uncommon in the cervical spine, because the sagittal plane, as you can see here, is really oblique with respect to the foramina. So the sagittal plane is much better for the thoracic and the lumbar than it is in the cervical. So some people like to do oblique imaging through the cervical spine, and this is the C6 level here. So what do you see on the oblique sagittal images?
I see it like a significant foraminal narrowing and disconnection.
And it's pretty obvious on the oblique sagittals, but it's not at all obvious on the axials or the straight sagittals. And one of our radiologists really always did these oblique sagittals over at Tower. And at first I poo-pooed it, but then when I started reading some of these, it wasn't that uncommon for me to see the foraminal disease much better on these oblique sagittal images. So we don't do that as a routine, but I think it's important to recognize that in the setting where there's really definite focal neurologic findings at a level, and it's not really well seen on the other images, it's not a bad idea to do oblique sagittals right through that area, because it can be helpful. And that's just, here's the straight sagittal, the best one we could come up with, and here's the oblique sagittal, and you can clearly see where that disc herniation is extending into the foramen there. Yeah.
I don't understand why the cervical would not lend itself to a straight sagittal. If anything, you don't get coronal malalignment as much in the cervical as you do in the
because you're not cross-sectional here. You're going through it at an angle. And if you do the oblique sagittals, you're going through it like this. So you're partial voluming the bone. So if you go this way, in this part of the foramen right here, the slices are thick enough. Remember, these aren't real thin slices. This is MR. So in this slice, over here, you'll get part of the bone involved, and over here, you'll get part of the bone involved. And because the slices are thick and you get partial volume, unless the slide is perfectly positioned right in the middle of the foramen, you're going to get a lot of bone that's going to make the foramen look small. So if you go here to the images here, what happens is we're partial voluming the bone on either side here. We don't have a clean cut right through the foramina. And this is quite common in the cervical spine. So generally in the cervical spine, I use the axial images to evaluate it. and if you have a concern that it could be bony problem, CT is much better. But for disc, CT may not be so good. And these oblique sagittal images can really be very valuable, because now what you have the imaging perpendicular to the tunnel. And so you get a nice view, just like you do in the thoracic and lumbar spine, where the sagittal plane is pretty much a cross-sectional. Now, there's a little bit of angulation in the lumbar spine, but the foramina are so much bigger there that the partial volume effects aren't as big of an issue. Yeah, so I just wanted to point out.
So how is it like positioned? What's the axis in sagittal oblique? Is it like tangential to the vertebral body?
You do it at about a 45-degree angle.
45.
Yeah, but the way they set it up is they set it up. Right here. What's that? Okay, they usually set it up on the axial images, so they'd set it up to be perpendicular to the foramen using the axial images. So they would set the oblique sagittals up through there, and then do a separate set through the other side. But sometimes that can be very helpful. Okay. So how are you doing this?
Lateral foraminal. I don't see any significant foraminal narrowing here. Foraminal open. If there's a disc protrusion, right percentile and neural foramina, and in the neck and ventricular sac on the right side, and going to the actually right.
Yeah, so this is a gradient echo technique. And still a lot of people use that. So that's really a lateral recess foraminal zone protrusion. Yeah.
Could you do away with
Talking to the mic.
I'm sorry, I'm just harping on this thing. I wondered, could you just do away then with the straight sagittal, or maybe just to get an alignment one, just do one quick shot through the sagittal, and then use the obliques instead? Yeah.
Now, the straight sagittals are the most important images, I think, in the cervical spine, because they're the ones who really let you see the alignment of the spine. They're the best ones for evaluating the discs. They're the best ones for looking at the disc protrusions in the midline. They're the best for looking at the cord and cord signal. So you can't get away without the straight sagittals. I do this. Okay. And let's see. Let me see who we have online here. Shiv, what do you think of this case? Unfortunately,
on the straight sagittal, it doesn't look like there's much going on. And on the, is that an oblique sagittal?
No, that's just a sagittal off to the side.
Okay. It looks like there's a focal protrusion sort of, going into the neural foramen.
Yeah.
Yep. 5-6.
So most of the time you can see these lateral or foraminal zone protrusions on the combination of the axial and the sagittals that aren't near the midline. But sometimes those oblique sagittals are really very helpful. Here the axial images show that lateral disc protrusion pretty nicely here, and the compromise of the foramen. Okay, Thomas, what do you think of this case?
So the two sagittal views, T1 and T2, and there's a disc protrusion at the 2, 3, 4, 5, C6.
Okay. Sagittal protrusion here, and then we get the axials and characterize it. Then we can see it deforms the anterior aspect of the cord, and then it'll be important to see the sagittal stir to see if there are any signal changes within the cord there. And here's a more lateral recess stenosis, another disc extrusion. We need to spend a lot of time on these. And here we can see a big extruded disc going off to the side, compressing the neural structures. Okay, well, why am I giving all the answers here? Okay, Thomas, you did the last one, right?
Shoot.
Yeah.
Okay. That's it. Okay, Sam, what do you think of this case?
Thanks. So yeah, there's a protrusion and there is increasing of the cord.
Okay.
Yeah.
And then here we can see a lot of increased signal in the cord. So what do you think is the cause of this signal?
Well, it's getting squished by the disc.
Yeah. And there's, if you look on the axial images, it looks like you have kind of owl's eyes here. See the two little things there? When you see that, there is some evidence, I'm not sure really how strong it is, but generally a lot of people believe that when you see edema on two sides like this, that's highly associated with ischemia of the cord due to the compression. So here we have compression, but many people believe that when you see edema on either side like this in the owl's eyes appearance, that's indicative of focal vascular compromise of the cord, and it tends to have a poor prognosis. Okay. Here's a little different. Here we have a more diffuse increased signal intensity within the cord. Here, and then here we can see another disc protrusion with compromise of the cord here. What's this? Oh, okay, let's see. Ahmed, why don't you take this one?
Okay, so axial and sagittal images for the cervical spine, large disc extrusion at 2, 3, 4, 5, 6, 5, 6 with indentation of the cord and mild flattening or decrease anterior posterior diameter of the cord.
Okay, and this just shows a more normal level here. Okay, and then after surgery,
Okay. So there is some surgery at the level. Seems like the extruded disc is gone, but there may be sort of and the interspace of the overcap. So small recurrent disc there, tiny bit on the left side.
so this was a disc spacer that they put in. So I don't know. This just shows that they put in a fusion with a disc spacer, but the disc spacer is very proud here, and you continue to have pressure on the cord in this particular patient, even after the surgery. And yeah, I forgot. I don't know what this is. Just I think I'm just showing a normal level, and this is the level where you don't see the CSF well, and you can see compression at the cord at this particular level. And here the disc spacer wasn't properly positioned. It was too posterior, so you're still having cord compression. And that was presumably the cause of the patient's symptoms. Okay. Sahar?
Okay. 2 sagittal and 2 axial views. It looks like we may have a congenitally small canal, cervical spine from C3, C4,
So we
and
have
there's abnormal core signal.
So we have a little protrusion here, and then we have prominent thickening of the posterior longitudinal ligament all through here. And then we can see the canal is very small, and you're right. There's a lot of atrophy of the cord and abnormal signal intensity within the cord. On the axial images, you can see where there's been this chronic pressure compromise of the cord, which has probably led to ischemia and atrophy of the cord in this particular patient.
How old is that patient?
What?
How old is that patient?
Young patient.
I don't know if we have we don't have the age in this particular patient.
What's with the thickening of the posterior longitudinal ligament?
That's a finding that can cause that can be symptomatic. Here's another patient. Let's see who's next. Okay. Shiv, what do you think of this patient?
Okay, 76-year-old female with neck pain. So similar to the last one, it looks like there's thickening of the posterior longitudinal ligament and multiple protrusions at several levels.
And then,
I don't see much signal in the disc this time, though, or the cord.
yeah, down below we can see it relatively normal, but we can see at the level of the thickened posterior longitudinal ligament, we can see more compromise in central stenosis with a lack of CSF without the cord to the right, without the cord signal. Some people call this a washboard spine, and it's indicative of chronic degenerative disease. And generally, these patients have oncovertebral disease and facet disease with a little bit of instability, which has probably led to chronic trauma on the posterior longitudinal ligament and thickening of the ligament because of that. Forget this. This is here we go. Thomas, what do you think of this patient?
74-year-old female with leg numbness and unsteady gait. So there's at C5 and C6 disc protrusion, and it's causing severe stenosis at C6, C7. The cord is compressed, and there's signal change in the cord.
Right. So the disc protrusions in the cervical spine, there's a much bigger worry that pressure on the cord could actually produce ischemia and irreversible cord damage than there is to the nerve roots in the lumbar spine. And therefore, there tends to be a little bit more of a continued recognition that surgery for large disc herniations in the cervical spine still may be indicated to protect the cord. You can't see it here very well, but there's a lot of increased signal intensity within the cord on the stir image, especially right in here, which on our projection on this screen we can't see very well, but on my computer I can see it much better.
I agree. I agree with you, John.
John, how are you doing?
Well, Marge is at St. John's Hospital.
Thank you. Okay, and then if we go to the axial images on this case, Thomas, what do you think here?
So we have a T1 and a T2. Yeah, I don't see any. Yeah, the CSF is completely effaced on the T2, and the cord is deformed from the compression.
So that's really very severe stenosis, right? Okay. So if you talk about stenosis of the cervical neuroforamina, there's a system that was published in the AJR back in 2014 by Park, which would be A, B is a little bit more narrowed. C, we can see that there's no fat above the nerve root here. Here there's fat above it and below it, but not anterior and posterior. Here we got three sides with no fat, and here we have no fat within the foramen at all. So these are A, B, C, and D. And they say that C and D are associated with, can be associated with symptoms. If we look at central stenosis, there's a grading system by Kang, where grade 0 is that most of the subarachnoid space is normal in size. Grade 1, you've got a 50% loss of fluid around it. Grade 2 is you have cord compression with no abnormal signal, and a grade 3 is we have cord compression with signal. And obviously grades 2 and 3 are significant, and many people believe that in most settings these require surgery to decompress the cord. The problem with these is at grade 3, even if you decompress it, you still have a high likelihood of not regaining all of the neurologic function once you have cord changes within or signal changes within the cord. So anyway, I don't know what's going on. So, see, Sam, what do you think of this case?
Actually, grade the stenosis. Looks like C3-4 grade 4 stenosis. I think there's a pretty signal there.
Well, it's only grade 3 was the highest.
Oh, the stenosis of 3 was
Yeah.
a pretty signal.
Yeah. And then there we can see, and there is abnormal signal, so that would be a grade 3 stenosis. Okay. Ahmed?
Okay, so C5, C6, and C6, C7, especially C6, C7 disc protrusion. Maybe there's a
Yeah. Maybe a little bit
very
up
hard
here
to see
too.
signal there.
Our primary thing down here is,
So grade 3.
yeah, up here, there's abnormal signal in through
Right.
here. So that would be, well, actually, with this grading system down here, there would be narrowed, but no abnormal signal in here. I guess it's hard to say whether there's signal there or not. Not the best study. Okay.
7-year-old progress in myelopathy. Can we have significant stenosis at C4, C5 with cord signal changes? It looks like it's not a grade 3.
Yeah, well, with this grading system, it's a little confusing here. So this grading, yeah, grade 3, sorry. So here, and then here the axial. What do you think of the axial?
Okay, the axial, again, I see like focal areas of abnormal signal in the cord. It's like cord ischemia, yeah. That's all sign.
So that's kind of an owl's eye appearance again, indicating cord ischemia.
That's close to what Marge has.
Yeah. Right. Okay, Shiv, what do you think of this one?
All right, neck pain. We have a T1 and a stir, and looks like there are multiple levels of degenerative disc disease in an area with sort of linear hypointense signal over the 3, 4, 5, C6 vertebral body. Okay, again, we see that hypointense area within the vertebral body. Could be vacuum disc, could be air from degenerative disease, we guess.
Here's a CT.
On CT, it sure looks like it's a vacuum disc phenomenon.
Yeah. So yeah, that's a vacuum phenomenon from the disc, with the gas from the disc extending into a small node. Okay, Thomas.
48-year-old male evaluated for MS. So I have 2 T1 images, and the cord is normal caliber, not much disc protrusion on the sagittal, and I guess the muscles look pretty normal.
So this was 1704. So we see a fair amount of degenerative disc disease, but nothing really to write home about. And the patient came back 4 years later, and this is what it looked like 4 years later.
So we have sagittal T1 pre, T1 post, and a T2 pre. And see on the post, there's no enhancement within the cord. On axial, yeah, there's a area of signal void,
Yeah.
or low signal.
Like the last one. Now this is, the patient then came back a year later, and these are the plain films.
So there's a lucency at the vertebral body, C6. So is that a vacuum disc with herniation or something?
Yeah, this is the same as the previous one. And then there are several papers in the literature that have shown once you see gas, it's a reliable indicator that you're not dealing with malignant disease or infection for that matter. Okay. Sam?
5-year-old with neck pain, stiffness for 3 weeks. There's 6, 7 discs. There's a lot of loss of signal there. There's also some other disc stuff. Not as pronounced. Yeah.
Yeah, I'm sorry about this screen.
I wonder if it.
What the study shows is that you've got little bit calcifications here. This is kind of more normal signal, and then you've got density right here in the middle.
Yeah. They injected that disc.
Yeah, I think.
They were a 12-year-old. They
Yeah.
do that. So. All this patient.
So they didn't inject it. This patient's had no procedures.
Okay.
Okay, but this is a kid, and this is there's a known phenomenon that's not common called a juvenile calcific discitis, which presumably is some sort of trauma, since kids have very flexible necks. Trauma to the disc, which then dystrophic calcification in the disc itself.
I would think of infection.
Well, these patients can have neck pain, fever, and elevated SED rates, so maybe you're right, John.
I really would. 10-year-olds, they just, I don't know how you can, well.
Yeah, but these are generally treated without antibiotics.
I certainly would.
But, okay.
Okay, so 69-year-old male with upper mid back pain. C5, C6, and C6, C7 disc disease, and changes, probably. Okay. Anterior longitudinal ligament calcification, interior disc, dish shape.
Yeah, so this is
Mid back, why would that be, John?
Say that again?
Why would the pain be mid back?
I just think it's what they're calling kind of diffuse upper back pain.
That's cervical spine.
Yeah, well, I think by upper mid back, they're talking about the cervical and upper thoracic spine area. But anyway,
Okay.
that's what the symptoms are. And you can certainly make an argument that the dish itself is not a symptomatic disease.
Well, I would certainly clinically evaluate, and you'd be able to tell.
Yeah.
But it's a little confusing.
Yeah, these probably are caused. You probably have limitation of motion up here. Like these are essentially fused discs, which would put a lot of strain on the disc spaces below this, and that may be what's leading to the lower thoracic and upper thoracic, lower cervical and upper thoracic symptoms due to the increased stress pattern on the disc spaces below the dish.
Okay, I'm a skeptic.
I just want to bring this up as a diagnosis. Now, the dish itself is often referred to as a diagnosis in and of itself. I'm not exactly sure what dish is, but I don't think that there's any. My guess is it's reactive to some other process which is producing the hyperostosis, rather than it being an independent disease. But many people consider it an independent disease.
But in terms of imaging, though, it's bright on both T1, T2, right?
Yeah, it's bone, so it has fat, regular marrow fat.
Oh, I see what you mean. So it's producing marrow then.
Yeah, marrow fat is seen within it here.
Okay. It looked like just fat.
Yeah. Okay. Next.
21-year-old female with neck pain. We have this protrusion at C3-4, C4-5, C5, C6, C6, C7, some canal stenosis.
Okay, so this was on 2/17/11. This is on 10/6/11.
Okay, so this is the anterior fusion. For the
Yeah, now
patient.
she has weakness.
Okay, so there are some material protruding into the spinal canal.
Okay, so if we go back here, so here we can see this level looks fairly open. We got a little bit of stenosis down here, not too bad inferiorly. And then now's what we're seeing is that you've got kind of a new narrowing at the level above the fusion, and we're probably getting a little bit of spondylolisthesis here at the level below the fusion. And it just shows that that when you start fusing in multiple levels, what you typically do is migrate the disease to above and below the level of fusions. Okay.
I'm not sure that this case, certainly not from MRI standpoint, and you would know better than I, the MRI wouldn't indicate surgery. Maybe clinically it would, but looking at the cord and so on, I don't know, John. This doesn't look like a surgical case to me.
Yeah, well, I think if, I don't know exactly clinically what's going on. I think it was just neck pain. I don't think there was any radiculopathy. But I would imagine in 71-year-olds, this is probably a better looking cervical spine than about 50% of 71-year-olds.
I certainly agree with you. A cervical collar at night for a couple of nights probably would help to cure it.
Okay. Shiv, what do you think of this one?
49-year-old female with new pain after surgery. So it looks like they've done
as good as that last one. Let me put it that way. Go ahead, Shiv.
It looks like there is anterior fusion here at C5 to C7 maybe. And the C4-5 level, it looks like there's a protrusion there.
Yeah.
Extrusion, yeah.
Okay, Thomas.
59-year-old female with prior surgery and new pain after MBA. So there's cervical fusion and
Okay.
yeah, that's all I can see on the pain column.
Yeah, so here we have an anterior plate, and then we have pedicle screws or struts posteriorly on both sides. Here's a CT scan.
So on CT, yeah, it looks like one screw is malpositioned, sort of towards the, yeah, it's too far towards the spinal canal and actually partially into the neuroforamina.
Right in through here, right. This one's not great either. And then here, you notice that the anterior plate is actually off to one side as well. And over on this other side, notice that there's also another screw that's going in through the foramen on that side.
Yeah.
What you can say is this patient really got screwed.
Okay, so this was just a problem with positioning of the surgical devices. Okay, Sam.
You're being kind. You're being kind, John.
Thomas here, the last one. Right?
I think so.
Yeah.
63-year-old bilateral upper extremity weakness sensible fall. So I think this is really bad alignment, right? It's just if we're up to the side here.
What's going on here?
That looks chronic, and been surgery.
Oops.
Well, okay, anyways, there's been surgery and the alignment is off. I'm really not sure, like,
Yeah.
what's wrong with the alignment, but it's not superiorly, it's especially off.
So here, the red arrow actually shows that you have a little mass here around the odontoid, which is calcified. The blue area shows that you can see some chondrocalcinosis, probably from degenerative disease and injury to the articular cartilage and the disc. The green arrow shows some cyst formation from degenerative disease, and you have some subluxation here in this particular patient. And there's a disease process called the Crown-Den syndrome. Are you familiar with that? Some people call it acute pseudogout of the neck. And it's really where you get calcification of the transverse ligament up. Usually it's right back in through here. And you get severe neck pain and stiffness. Some people they think that you can get that fever, and many people believe that it's an inflammatory condition. Personally, like a lot of other areas where you get calcification within ligamentous structures, I think it's much more likely to be due to trauma and dystrophic calcification, and that the pain is really due to traumatic injury to that particular area. But certainly it is possible that you could have it due to inflammatory conditions, but it's called the Crown-Den syndrome. Crown-Den syndrome. Be aware of that because it's a lot of people don't know about it, and it's often kind of missed. But it's usually treated conservatively, as you might expect.
That's C2, C1, I mean C2-3 looks like it's unstable.
Yeah, and this is unstable again, probably because we have the fusion down below, putting increased strains on the mobile disc, the area just above it, and that's really holding the whole head. So this is probably from chronic strain, abnormal strain of the C2-3 level.
I would worry about riding in a car, I'll tell you.
Yeah, I agree with you, John. My guess is that this is much more significant than this.
I agree with you 100% on that.
But both of these may be due to increased stress patterns from the fusion below it. So there may be a common cause for those.
The other images show that.
What?
There were other images to the side. Were those showing something related?
I mean, here?
And before?
This just shows the calcification here in that, and this shows all the calcification around the dens here, which is what you see in the Crown-Den syndrome.
Probably traumatic.
Yeah, that's what I think. Though that's not what the bulk of the literature says, but that's what my
well,
guess.
Like I said, 5% of the literature you can believe, maybe.
Okay. Okay. Let's see. Why don't we stop here, and we'll pick up on trauma when I get back. So I'll be. Let me just. We don't need.